Yeah, thank you so much for having me and for the kind invitation. I'm very happy to be here. I got the title Clinical EV Diagnostics. Are we there yet? I added that. I'm a physician scientist and a kidney doctor, and I see patients every week, and this is really a topic which is dear to my heart. We have a lot of silent diseases, and we need to find better biomarkers. So why is there so much excitement about EVs as novel biomarkers? And I looked up some market analysis, and I'm not a market analysis expert, but I found some data saying that the global biomarker market is really this year about $81 billion. So it's a big market, and it focuses a lot on cancer biomarkers, cardiovascular biomarkers, and it likely will double in the next 6 years. So it's really a big market, a lot of money. This is in general biomarker development. And then I put extracellular vesicles, exosomes, and biomarker in PubMed, and I saw what Andy Hill found. You see this accelerated increase in over 10,000 studies every year now in biomarker development or over the time, span. And maybe there is a plateau, Andy. We see that as well. And then I looked up mainstream media, Washington Post, New York Times, and they are starting to report about using EV biomarkers for silent diseases, in particular deadly, like ovarian cancer. So people are reading about it, so I thought that was exciting. So why do we need novel biomarkers, and what is really unique about EVs as biomarkers? So as a kidney doctor, I use biomarkers to diagnose diseases. I monitor biomarker when I give patients medication. I check their response. I check if the drugs are safe. I assess their risk. Is someone going to have a bad consequence outcome? And predictive biomarker, what is going to happen in my patients in the next 2 years. And we all are very EV enthusiasts, and we think that we might find the needle in the haystack in these EVs. We just heard that they might harbor these interesting biomarkers we don't have yet. I mean, it's actually pretty disappointing as a clinician. We don't have a lot of good biomarkers. So they might the EVs might protect the biomarkers. What I found also very interesting is that beside the cargo, the origin is known. They could be site-specific. We can know where the biomarkers are coming from. They also can give us hints towards the molecular processes. They could be disease-specific. We have many diseases where we have many phenotypes. So it's diabetic kidney disease. We have many phenotypes, but each individual phenotype might need a different treatment. So we can better personalize care. And we want to also know what's going on in the tissue. So this kind of keyword is liquid biopsy. So we need early detection, ideally non-invasive, and the urine is one good biofluid for that. So overall, EVs are really unique. They're not just diagnostic, prognostic, but also therapeutic, and we just heard regenerative. As I said before, I'm not a market analyst, but I found it fascinating to look at the market analysis for EV research products, including biomarkers. It's really amazing. In the next 5 to 10 years, this is going to increase from 15 to 30%, and it's $1 billion market. And you can look in different studies, and you find the same story. And Ronan Payton, who works for General Exosomics, he used search engines for business questions, and he looked up which companies exist right now who produce EV research products, and half of them do therapeutics and about 15% biomarkers, so that's quite a good number. And then when you look down, where are these companies? So quite a lot in the US, I was surprised, but also in South Korea, Italy, all over the world. So I found that also very interesting. So let me give you some success stories of conventional biomarkers. When I was a resident, I was glad to have the troponins to diagnose acute myocardial infarction, a heart attack marker, specific, early, impactful. It's a fast and simple detection, and it can be even more impactful when you combine it with clinical information, for example, with an EKG. As a kidney doctor, we don't have this kidney attack marker. Our kidney markers are very delayed and non-specific, and we would love to know where the damage is in the kidney, in the cortex, in the medulla, or is it in the glomerulum or in the tubulum. So we want to get hints at the mechanism, the etiology. As I told you before, there are a lot of phenotypes. And in my lab, we do right now a lot of targeted EV phenotyping with flow cytometry to look at where are these EVs coming from in kidney disease, more from the podocytes or tubular. So we are developing these tools, and hopefully that's why I'm excited about EVs, that they can be disease and site-specific. So let me give you an EV success story. Many candidates are already identified. Only few made it to the clinic or on the way. And one good example is really the prostate cancer, ExoDx prostate IntelliScore. There is a real challenge to predict which men are likely to have high-grade prostate cancer when the PSA, the biomarker used, is in a gray zone. And this EP testing is an exosomal genomic marker signature for risk assessment and helps the clinical decision-making. There is actually a cut point, and if it's lower than 15.6, these men don't need a biopsy. And this has really consequences. These biopsies have side effects, and it can lead to overtreatment. So very impactful biomarker. And actually, this biomarker checks a lot of boxes you want for your biomarker. It's simple. You can collect the urine at home, non-invasive. There is no digital rectal exam needed for some of the PSA tests that's done. It's validated in several studies, over 1,000 patients in real-world settings. And it's seen as a complementary with other clinical information, together with the biopsy and the PSA, and also in the future, MISWAR imaging. It's really meaningful and impactful. It avoids unnecessary tests. And the last point, I'm not giving a checkpoint yet, I tell you later, the clinical implementation, and I'll talk about that, there is likely still clinical inertia there, not enough awareness of EV testing. So let me now come to the part where we were asked to talk about hurdles, roadblocks. I also would like to call it next steps to bring EV diagnostic to the clinic. I want to be a little bit more optimistic here. So the Urine Task Force, it's one of the subcommittees of the Rigor and Standardization Subcommittee of ISAF, is working currently on a review for roadblocks of urine EVs to clinical translation. And they gave me permission to show some of our figures. But this concept I'm talking about for urinary EVs can also be translated to other areas and biofluids. So you're getting a little bit of a sneak preview here. And we kind of divided these roadblocks into four major ones: fundamental, technical, approval, and clinical. And let me give you some examples because of time limitations here. Let's start with fundamental. So focusing on urinary EVs, we still have insufficient knowledge of the UEV origin and cargo. We know more. We know already a lot, but we need to know more, and more physiological studies need to come. We also need to fully understand on UVE excretion rate. So it's not just the UEVs are filtered in the urine, but they can also be excreted and reabsorbed. So what's really coming in the urine? So we need to understand more of that, and that will affect our biomarker discovery. These are very fundamental roadblocks. Let's talk about the technical ones. And you see already, I have listed here 5, from collection, normalization, etc. Let's start with collection. So there is really a lack of standardized collection and storage protocols available, so that's a hurdle. However, the Urine Task Force wrote recently a collection or a report card for how to collect and guidance for people who want to do EV research. And so if we standardize these collection in different labs, we can do the validation Andy Hill talked about. Normalization, there's imperfection of known normalization parameters. We need more housekeeping proteins or markers. Detection technology, there's extreme heterogeneity. We talked about it already. And data processing, I will come in a second. But I think for each of these hurdles, we already have solutions. We just need to approach them in the next coming years. Let's talk about data processing, and I'm not an expert in this, but there is a lot of untapped information here. If we have all these omics and clinical data, we can put them together and integrate them. However, another hurdle is here that all these data arrive from different protocols people are using and deriving these data. So we need to synchronize protocols, plan and structure the experiments better, use computer models for data integration. And also, it's not that each EV is reflecting what's going on. It's not a miniature expression of the cell. We also need to develop pathway and cell type profiles for interpretation of EV omic data. But David Greening is here the expert, so I will go on to the next topic. assay development. Everybody thinks, okay, I discover my biomarker and then assay development comes at the end of everything. No, 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 no. We need to think sooner about this. We need to first understand what does it mean, assay development. It's an analytical validation, it's a clinical validation, also the clinical utility and economy. We need to see what is the reportable range, is the test robust, how precise is the test. And it starts actually very early. The problem starts very early because our usage area is poorly defined. Andy talked about that. We need to know what we want to study. We need to have a better focused study. We need to know what we want to find. We also need to understand better how to do validation. And we also need better infrastructure and knowledge and performance testing of assays. So learn about this topic as early as you can. The same is with approval roadblocks. You think, oh, that's at the end. But it's very complicated, and we need to learn about it. And two big hurdles are that's actually really costly. And I think that's something hopefully will get better. And there is a changing regulatory landscape. And I think what I understand right now, it's a little easier in Europe than in the US. The FDA has more questions about that. So clinical roadblock. We're almost at the end here. As a clinician, I see there is a problem with clinical inertia, that doctors are really reluctant to implement new testing. We need more education and EV awareness. And I also think that in the clinical, it's not clear right now if some tests can be done in each individual in each hospital, or if it has to be centralized. So this prostate cancer biomarker is actually a centralized test. So that's working for that company. And now let me come back to this EPI-score, to the success story. However, I think there is clinical inertia here. I just attended, a few weeks ago, medicine grant round in a tertiary care hospital it was UVA, sorry. But I listened to a talk about prostate cancer, and this EPI-score was not mentioned. They talked about PSA and imaging and everything. So we need to bring this knowledge to the community. And also, when I talk to family members and friends who have prostate cancer, they don't know about this test. So I think there is still a lot of work we can do and have to do. 2 more slides and I'm done. So what's my ideal biomarker? What's my wish list, single or together with clinical information? We need standardized methods with a robust and rapid analytical platforms, and we heard about fantastic talk about the new technology out there, small sample size, and in the end it needs to be clinically meaningful and impactful. I want novel, fast, and ultra-sensitive detection and capture multiple signal in clinically feasible samples simultaneously. Label-free approaches, I told you that. And of course, it has to be validated in clinical settings and large cohorts, like the thousands. Most people, when I started, 10, 20 here, now we're in the hundreds, we need thousands. Okay. One more, what's on the horizon? There is a light at the end of the tunnel. We need novel technologies for single EV analysis with and without labeling. With high throughput tools, I think flow cytometry is already there. Upscaling EV diagnostics. We need more standardized protocols, but we have all the task forces, position papers, collection cards, more tools for standardization. We are having already some reference materials, which is really good. We need larger cohorts, studies, more awareness, increased collaboration. Maybe this is the most important between scientists, industry, and funding agencies. And now I want to thank you, my lab, university, collaborators, funding, and all of you. And at the end, I hope you allow me to also advertise. ISAF has a new special interest group on genitourinary system EVs. As a kidney doctor, you can imagine this is very dear to me. It's co-chaired by Erdbruegger, Elena Martens-Usunova, and Monica. And we are having a satellite meeting tomorrow evening, very exciting talks at 5:45. And our vision is really that we foster and focus on education in this field, cross-society partnerships, cross-disciplinary collaboration, and professional networking. Thank you so much.